We only have one of this left, so we can't open it.
I'm gonna be like,
But this is for the summer core. And we have a liver piece going
yeah, with
on.
this angle
We
too.
took the summer core machine out of our workroom. Did you guys hear me?
Yes.
What did I say? Okay. Did you guys pay attention? I don't want to repeat myself because we're very limited on time. So what I said is that the thermocore is not here because we have a liver and they wanted two machines. So Alan's gonna show you the tubing and how to connect it to a Ranger high flow. Remember I mentioned to you in class that you can use a Ranger to give high flow fluids. And then use it to connect it to make a Y, because apparently in 500P, they typically have a Y connection for the thermocore. And then the other day, they asked for a Y connection for a Belmont, which we don't typically do. So Alan's going to show it to you.
Okay, so is this always going to be just infusing blood?
Yes. So not just blood and blood products. So plasma, platelets.
Who's there? Jessica's there looking at it.
You want to tell them what you did?
This is not going to be fun. So, if you look at the Y-type tubing, what's the Y-type tubing? So if you look at this Y-type tubing, it has this plastic connecting piece. It's identical. This piece is carried in cardiac. Perfusionists use it when they run the perfusion machine. They have different sizes. I accidentally rubbed the wrong size. It's a 1/4 inch. What that means is the hole is a 1/4 inch. And for the Belmont, it's funny that she's asking for this because earlier today, one of our techs was teaching the rest of the staff. He had an incident where the anesthesiologist asked for a Y-type on a Belmont. All of these are thermocore specific. It won't fit in a Belmont. So what he did was, he grabbed a Y-type, which is the Y-type, this is the Y-type, and he added a female to female adapter on this. So pretty much you cut this, you add another port, and you shove that, pretty much you shove this piece inside here, and it creates a seal, but the other end is a female. Then you can add a female to female, and it'll become a Y type. And then it'll fit in the Belmont.
So that's when you don't have the correct tubing.
Correct. They don't make Y-type tubings for a Belmont. I'm sure they
Why
do.
would they use a Y-type tubing for a Belmont?
It's,
Why do they need it?
well, I mean, they probably have two different ports to access or give the patient to, just like they would want to do here. One port will be for rapid infuser for the blood, and say if that gets clogged, they wanted to use another end. Why else? I wouldn't know why doctor wanted to use it.
I'm just thinking out loud why they would ask for it. The other option is if they want to separate it, one can go to the groin,
Yeah.
the other one can go to the arm. And that's why they probably want two separate ways, just like our IV tubing. When you spike, you choose one, and then you can add another bag if you want. So that could be a reason as to why they want it separated without having to have another machine inside the room.
Pretty much it's this, but a Belmont fitting at the end. The Belmont tubing has a male end, so it'll be a female end connected to it, so it'll fit it. Pretty much it's MacGyvering it, which we're not supposed to do, but we don't have that correct tubing, and not every time to ask for it.
How frequent do they, so they don't ask for it frequently?
They don't ask for it all the time. There are specific anesthesiologists at Stanford who use it who use a thermocore with a white type tubing. There's only two. So whenever they're in the case, that's one of the things that they would want is a white type connection at the end.
So where did you grab this? This piece.
That's perfusion.
So you grabbed it from their workroom? Okay.
They have different sizes.
And then the one that we use would be quarter inch.
It's a quarter inch.
And this is not a quarter
No,
inch? Okay.
That's rough too.
Okay.
So this is a half inch by half inch by half inch. They'll say quarter inch by quarter inch.
All right. Is there anything else? Okay. I'll go over the other with them.
Thank you, Alan.
So we don't have a thermocore machine here. So when we have an opportunity when we come back and have the thermocore machine, we'll show you how that one sets up. It's just that Dr. Horn is doing a liver case today. And they have both machines in 500 feet. Okay.
So as far as what is the thermocore the most productive as far as how fast it can move the volume?
So thermocore, I believe, is 1,200 ml per minute. So basically, I can take one full bag of this and a 200 bag and infuse this all into the patients within 1 minute, 60 seconds.
And so it warms it to the patient's body temperature?
There's a warmer setting on here. So you can actually warm the fluids as you're giving it to the patient. There is a warming sensor here. It's like a plate that heats up the tubing to keep the fluid warm as it's going into the patient vessel. Actually, one of this caught on fire. Is it this one?
Yes.
Yeah, this one caught on fire. The case had been going over 12 hours? Over 12 hours. And you could smell smoke. And so they had to disconnect the line. Alan was here at work. He discovered it. He's the one that retrieved the cassette. But this metal right here is what caught on fire. So you really have to pay attention to your surroundings because you have a lot of electronic devices, you have a lot of devices that cut, and you have all these connections. And this machine, it can only go so long, right? After a while, it overheats, just like a car. After a while, your car overheats, and this is what was done. And a safe report was filled out because this is not meant to go on fire during a case, right? You're relying on this to give fast delivery of blood products. So I mentioned the thermocore gives 1,200 ml per minute. This Belmont is 1,000 ml per minute. So if you have 1,000 blood hanging here, the physician can give and deliver 1,000 ml of the blood, back to the patient in 60 seconds.
So if typically liver cases, if it was a trauma case, would they have the time to set one of these up?
Not they, we.
Would we have the time to set one up?
No, that's why you plan ahead. Number one, this is battery operated too. Don't wait, and because you're too busy, you don't plug it in. You should always have this plugged in the workroom, okay? And this needs to be hooked up to a red plug. This is a critical care piece of equipment, right? You don't want this stopping during the case. And then, aside from charging it up, you're the one responsible for setting it up. So we're gonna go set, while you're here, Ellen, we're gonna go set this up.
How warm is the fluid that is going to the patient?
It will show here. You have a range of what you can choose.
Yeah.
So,
And how fast you want it to go.
So have you guys seen these used in a lot of traumas?
This is our go-to for the trauma. So, an example. Here we go by 99. Valid. I have a 99 coming. Can you set up room 8? As a tech, we have a regular trauma setup, but instead of level 1, we give them a Belmont. But before we even do that, we have to probe that trauma. What kind of trauma? Now, if they tell you a GSW to the abdomen, you know they're going to need everything. Meaning that they're going to need a TV machine, cell saver probably, Belmont, the works, because it's obviously going to be open. You don't know what it is. It could be something simple, it could be not. So you don't want to be stuck in that situation where the patient's here, now they're bleeding, and now you have to go make one. But we do get that 10 minutes, maybe 5-minute heads up to make it. There are sometimes the patients are bleeding through the door as we're getting everything ready, but that's the situation we're in.
Don't you have those machines in a particular room that's near the nurse's desk?
No. These are in our workroom because we're responsible for these. We make these.
On weekends, you don't keep a setup in one of those rooms?
That's the trauma setup. We have a trauma setup ready, yes, in a room, but it's not a Belmont, it's a level 1. It's the other rather than that one.
Okay, so this is the reservoir, just like this one of the salt saver. It has a reservoir with a filter inside, okay? And this hangs in here. And it has 3 ports, and it has 2 spouts. It has a single, a double Y, and a single. It doesn't matter where you go. And then as you learn, as soon as you put this in place, you want to clamp. And you only, when you're ready to spike, you only unclamp the one that you're going to use. Okay, you want to clamp. Okay. This is the spike set. Reservoir, spike set. In Cell Saver, it was called bowl set and reservoir. This is spike set and reservoir. So you basically would just want to follow the color and the direction of the tubing. So you see there's red and there's blue. The circle compartment goes in the middle. You follow it. You want to make sure the tubing that has to go in the sensor is pushed all the way in. Do not use your fingernails or scissor to poke it because you're going to slice the tubing. The worst thing is you're giving blood that you need, you slice this tubing and all the blood is on the floor and you've lost all of that perfectly good blood. And it has happened in the ED where the tubing got sliced. Okay, so while I'm putting this in, you always want to double check that all of the ports, the connections are secure.
Take this one out. Take this one out.
Yeah. There is a dual filter here. Go ahead, you tightened it. I'm taking this out because we have this big one. You see it?
Do you do that all the time?
Yes. If you work somewhere else, they might have a different preference, but the preference that our physicians want a big reservoir.
So they don't use this in conjunction with a cell saver? 'Cause
They-
the cell saver is gravity into the patient, right?
Gravity into the patient? Yes.
This might be the blood that was pre-donated, or it might be donated.
That's correct. then the other piece that you connect here is a extension set level 1. Okay, this I just pulled, we have them carried in the workroom next to our level 1 tubing. There's also the same sort of tail. This is called extension tubing that we use. You connect it. You want to turn the dial pointing to the stopcock end. Okay, so this is your end. This has been closed. Stick the tape off. Do you see how much time it takes? It takes a little bit of time, right?
Yeah.
And you still have to spike it, and you still have to prime it. And you want to make sure the machine is working, and the patient's like bleeding to death. So you want to already have this like ready to go beforehand.
Just out of curiosity, what's the fastest time in which this person managed to set this vision?
I don't know, I've never timed somebody. Typically when your adrenaline starts running, people go. I'm not going at a fast rate right now. I'm trying to explain it. But if I had to do it,
Maybe that.
yeah. So you want to connect the pieces up here, click it.
No, it's good.
Is it? Oh, okay, thank you. Everything is closed. This is clamped. You want to make sure you check, double check that everything's been clamped off. I'm leaving this open. We're going to turn on the machine. Let's have a volunteer, anyone. So you turn on the machine. Is it plugged into red?
Yeah.
Okay, plug it in all the way, okay? Turn it on. Let's face this way, your audience. What does it say, Quinn?
Does connect fluid bags.
Speak up.
Connect fluid bags, unclamp lines, and press prime again.
Where's your gloves? You have your gloves? So, I'm gonna have Quinn spike it, and I'm gonna have him stop at 200, right? You're gonna stop at 200.
So we're trying to
Yeah, so that means make sure you clamp, you clamp this off
do
at 200.
Alright.
Here.
Alright. So connect fluid bags. So you almost like the normal?
Yes. No. That's an expensive waste.
I can spike anyone?
I'm
I
sorry?
can spike anyone?
Yes.
Right there in that area.
What?
Trash.
This is trash?
Yeah.
But why are you wasting that?
I cut it.
Remember, you're gonna stop at 200.
Alright.
That's silly, but I can just picture like New Year's Eve, putting booze in that thing.
Oh, you wanna give yourself a 1,000 ml of booze? Okay. Or coffee? Thank you.
Thank you, Alex.
Thanks, Alan.
Is that the right stack? So normal salt?
Yes. Yes.
And self-saver, we don't use normal salt, we use normal saver.
I'm sorry, so is it normal salt?
Yeah, normal salt for Belmont.
So I stopped at 200.
Okay, you stop at 200?
Yeah.
Okay, excellent. So you stop at 200, okay? This is normal salt. And then what we're gonna do next is it's telling you to connect the fluid bag. Did he do that?
Yeah.
Okay. Unclamp the line and press prime to begin.
So I'm clank and press
No.
prime.
Hold on. Is this unclamped?
It's a clamp.
Okay, so unclamp the line.
Press
Okay.
prime.
Hold on. I have to explain it.
Okay.
It's easier to do it than I have to also explain it. So 200 ml, this is a preference. Our physicians prefer to have a minimum of 200. It can change. and to have normal salt used to be inside the reservoir, okay? It could be 500, it could be the whole bag that they may ask for. Okay. And then, once you have that done, you're gonna prime it. So in order for this, what priming means is basically getting all the bubbles out, okay? So where I said hold on because you don't have anything on the floor to collect the
Oh, I
fluid.
see.
So you're gonna put this on the floor.
It's gonna fall out of here? Oh.
Here.
Alright.
So,
Prime.
Farrah, you wanna hold this one and then he can prime? So in order for you to prime Quinn, you have to hold onto the button, okay?
It's already doing it though.
Okay, good.
I don't have to look.
So it goes faster if you hold it that way.
Huh?
The older machine, you have to like hold onto it.
System prime. Prepare patient line. Press patient line prime to pump at 50 milliliter a minute. Or press and hold to pump at 200 milliliters per minute. So just hold it.
Yeah, so you're gonna hold, now he's gonna hold the button and it's going to debubble the tubing. Yeah.
Whoa.
Okay, once you see that you don't have any more bubbles in your line, so this goes against gravity, so you need to kind of lift it upwards, have it travel, because you don't want to lose all your fluids. Okay.
Now we can stop.
Okay, stop, press stop. Stop. Okay, excellent. We're gonna take this, and then we're gonna hang it. Let me put it down there. Thank you. So this is what you would consider a setup, primed Belmont setup. You would unplug it, and you can walk out of the workroom into the operating room, and it will not turn off, as long as you have enough battery power in here. And then once you get into the room, you want to find a red outlet, either against the wall or on the wires that are hung up from the ceiling.
That's
Plug it
the
into
tubing
red.
is falling off.
Is this part?
Okay, so Diane, so you've got Normasol in there, and that's what you use to prime it, but typically, aren't they infusing blood or blood products?
Yeah, it's,
Okay, so then what happens?
okay, then what happens afterwards is, then they'll connect this, they will hook this up onto, so this tubing is different from an IV tubing because this tubing is a high flow.
Yeah.
Okay, meaning that there's a bigger diameter in this tubing than a regular IV, and you can actually connect this to a bigger bore IV gauge. So they would use typically like a 14 gauge IV versus a regular 18 or 20 gauge IV.
Would they do it in the arm, or would they do a central line?
So this, I've seen them use it on the groin or the arm.
So femoral or?
Yeah, femoral line. You have like a big vessel down there,
Yeah.
they'll use it here. So they can connect this for liver transplant patients, they always will have a femoral line and an art line. And they will use this to connect it to the Belmont, okay?
Yes. So, just one more question. So the blood that comes from the cell saver that is washed with normal saline and heparin or citric, you can use it with Belmont and wash it with normal salt, right?
No. No, so Cell Saver is separate.
Yes.
So Cell Saver is washed with sodium chloride, not heparin.
Yes.
It is mixed in with heparin or citrate for Cell Saver.
Yes.
This is not, it doesn't use an anticoagulant because you're infusing it right away. You're using this because you need it right away. Whereas a Cell Saver, they're conserving the red blood cells when they're ready to reinfuse the blood back to the patient. And sometimes they might wait until like the middle or towards the end of the procedure to make sure that that they have the blood volume they need for the case.
So the collected bag that comes from the cell saver, do we use it on Belmont or no?
Can you use it on the Belmont?
Yeah.
Yeah, you can use it on the Belmont.
So that's already washed with heparin and normal saline, right?
No, do not use wash with heparin. It's not wash. It is washed with sodium chloride.
Yes.
Yes. So you're just using this not to wash, but this you're just using this to dilute the blood because your blood is thick. So when it's going through the vessel, they're using it to make it thinner, not to wash it.
Okay.
Because the blood that is like a donated blood,
Yeah.
that's not like dirty blood. Like when they take blood donation from you, it's from a clean site. It's not from like an open surgical abdomen where they have cancer cells and where they have,
Yeah.
bone cement. Like,
Yeah. So this just it's mixed with the blood that comes. Like the collected bags, they got mixed with the normal salt to go to the patient, right?
yes.
Isn't that like a lot, like the same blood for the patient goes through in the cell saver, washed with first and then collected and then mixed with normal salt again?
The
Isn't
cell
that
saver?
like, yeah, isn't
Yeah.
that like too much?
No. So the cell saver, when you're giving that blood back to a patient, it's going with a blood pump tubing, like the one that you spike.
Yeah.
So you have one that's going to the normal cell, and you have the other one. You can connect the cell saver blood, and so you turn on the blood pump.
Oh,
You can give the blood back, and it has normal cell on the Y. Yeah.
thank you.
How do they know how much to mix?
I'm sorry.
How do they know how much to mix?
How much? What do you mean to mix?
Oh, you're saying that there's normal salt and blood. Do they have the normal salt open?
Yes.
And how do they know how much?
They'll look at the blood bag, and they'll look at the blood bag, they'll look at the normal salt. There's not like a ratio of how much normal salt and how much blood. It's just the flow. If it's seen as thickening, they'll use the normal salt to kind of thin it out so it goes in. Because you want that blood product to go in.
Yeah.
So this sounds, I'm sure this is a really stupid question, but, so when they're connecting, this to the patient, it's going to the femoral vein.
Yes. Yes.
Would make sense. It'd have to be under pressure for one thing, if it was going to the artery, and then it would be going back out. So they want it to be going